All right. Good evening, everyone, and thank you for staying put. It's that time of the day, and we'll try to keep it brief. I'll talk about patient-reported outcomes in type 1 diabetes, more like a summarization of what you have heard through the conferences and what my esteemed colleagues have talked about. We'll go through what is the value of patient-reported outcomes in type 1 diabetes patients, what has been done so far, and what are some areas of opportunities. My name is Jigar Rajpura, and I work with Novo Nordisk. Amongst other things, my responsibility at Novo Nordisk is to lead the health economics and outcomes research strategy for insulin and digital health. I'm also a health economist by profession, which also means perhaps I'm the kryptonite of patient-reported outcomes, especially if I'm coming from the United States. I'll go more into those details once we get to the conclusion of the slides. Patient experience of type 1 diabetes. Type 1 diabetes patients suffer from a multitude of psychosocial, psychological, and intangible burdens. These burdens start as early as childhood age. They prevail through adolescent age and as well as in their adulthoods as well. When these patients are children, it's their parents that are most impacted. They are often stressed about their children's type 1 diabetes management, coming up to terms with a chronic condition like type 1 diabetes, and that often leads to depression in parents and caregivers taking care of the children. By the time children reach adolescent age, it's during this time that the children itself go through an identity crisis, trying to come to terms with their chronic condition like type 1 diabetes, which often leads to a power struggle with their parents. Eating disorders and depression is fairly common, unfortunately, in the children in adolescent stage when they are going through type 1 diabetes. By the time these individuals reach adulthood, they often feel that the type 1 diabetes is inhibiting them in identifying a lifelong partner. Several parents have also reported, parents with type 1 diabetes have also reported being concerned and stressed about in passing over their genetic traits to their kids. It's a fear that has been living through childhood age and continues to through the adulthood as well. Let's look at some literature and some exact quotes by these patients as well as parents and caregivers. Patients feel that there is no quality of life with diabetes. They feel that they just cannot do whatever they want. They are afraid of being labeled different. They are fearful of opening up about the condition to their peers and colleagues by being in the fear of being judged by them. Parents often feel that they are helicopter parents, hovering consistently over their children who are trying to manage the type 1 diabetes, just adding on to the turmoil and the stress associated. My colleagues have briefly talked about the importance of clinical burden, but although across this conference you would have seen there have been several systematic and technological breakthroughs of yesterday and coming up in the future. However, the patient burden of type 1 diabetes, despite these advances, still remains significant. From a study within the US, 1 in 5 children and 1 in 3 adults are still struggling to get to their HbA1c targets. A qualitative interview of 41 patients across 3 countries highlighted that trying to get to an HbA1c range was a primary concern for the patients with type 1 diabetes. Like we have talked about, like you all know, clinical outcomes such as HbA1cs are really easy to capture. I'm a health economist. Associating these clinical outcomes to economic outcomes or economic metrics such as healthcare resource utilization and costs has also been pursued. And we keep talking about this intangible burden. Thankfully, we have patient-reported outcomes that help us paint a patient perspective and capture those intangible burdens. As a matter of fact, patient-reported outcomes actually have a central role specifically with type 1 diabetes patients. The type 1 diabetes condition itself is so unique, which requires self-management and frequent decision-making, thereby transferring the onus of determining their clinical outcomes on the patient's behavior itself. A patient having a better experience with the treatments will likely have better clinical outcomes and will likely have better economic outcomes, and therefore that may have a positive reinforcement loop feeding back to it as well. In fact, there was a published study across international authors that had a qualitative interviews conducted with academic trialists, journal editors, policymakers, funders, and formulary decision makers. Fortunately, uniformly, all of them agree with the impact of patient-reported outcomes in the trials and the need to capture them in order to have an evidence-based treatment or an individualized medicine for type 1 diabetes patients. As a matter of fact, for this particular presentation, we did look up how many patient-reported outcome measures do exist. There are around 17 type 1 diabetes specific patient-reported outcomes that are specific for type 1 diabetes, not the ones that can be used for type 1 and type 2 as well. 17 specific for type 1 diabetes, and a lot of them are being used in clinical trials as of today. Not only that, there are several institutions that help and provide the PRO implementation guidances as well. However, implementing PROs in clinical trials is not without challenges. Suboptimal trial designs that prioritize clinical endpoints and trials powered for clinical endpoints do not do justice to PROs. Oftentimes, PROs may read out in non-inferior or non-significant or not statistically powered. That's associated with the priority of the endpoints within the trials itself. Thinking of adding a PRO in a trial, well, that comes again with a participant burden and burden of training the staff as well. Not only that, the staff needs to be trained consistently, and the staff needs to implement, the trial staff needs to implement those PROs appropriately. Otherwise, improper implementation is going to lead to potential biases. Now, let's see that everything went according to the plan, everything has been implemented and translated appropriately. However, at the end of it, translation and interpretation of PROs, again, is not very uniform or standardized. Well, let's answer for if that's done as well. But how do you make a decision with respect to a PRO measure that's a low or high value with respect to your other clinical decisions and economic decisions? That connection still lacks. And all this collectively boils towards limited evidence and limited application of PROs altogether within the health system. It's the end of the day. I don't want to leave everyone with a dismal, sad day. I do want to highlight there are opportunities for future use of PRO in type 1 diabetes, quite a few of them. There are underexplored burdens. Literature has shown impact on suicidal thoughts and behaviors and association, which is associated with the diabetes. It's yet to be explored further. Literature has also commented briefly on impacts concerning siblings and within type 2 diabetes, still yet to be discovered. My colleagues talked about novel therapies. I'm glad that PROs are being included in these therapies right away within the trials. More of this needs to happen. Incorporating PROs, getting the patient voice, and understanding what they really want to achieve would only lead to patient success, treatment success, and provider acceptances of such treatments as well. PROs in real world. Most of the PROs that we have seen are usually implemented in a trial setting. It's a controlled setting. Translation of the same PROs in a real world setting often is lacking. I come from US. Most of the database that we use for analysis is claims database, administrative databases that do not, unfortunately, capture patient-reported outcomes of any kind. It would be really important to be able to capture that story and that perspective as well, especially in a condition like type 1 diabetes, where patient voice is so supremely important, impacting the significant behavior of determining their outcomes. Exit interviews. Some of my colleagues have very fairly mentioned the use of exit interviews. However, more of this needs to happen as well. I'll leave you with some key takeaways. Patient experience in type 1 diabetes goes beyond clinical burden. There is a multitude of psychosocial and intangible burdens associated with these patients with type 1 diabetes. PRO plays a central role. There are certain PROs that are available. Thank you for Sanjay for teeing up the idea. There, however, still is a lack of development of newer PROs. Several questionnaires are also available, but fine-tuning them for specific audiences would still be necessary. There are guidances available for implementation of PROs. However, actual implementation remains challenging as long as the return of investment is justified for those. And there are several opportunities as well within some concepts that are still to be explored and some novel therapies that's coming up in the future. It's a bright future for sure, but more work needs definitely to be done. I do want to thank Strategy team and Clarity team for helping me with the presentation. And whenever the presentation shared, there's a list of references. And to this point, I'll hand it over to Janet. Thank you.
So hi everyone, I'm Jeanette Soderberg. I'm Director of European Research at JDRF, and I'll be kicking off this discussion, and then I'll be opening up the floor for questions from the audience. So thank you all, fantastic speakers, very interesting talks. Monsi, I hope that you hear us and everything's technically okay.
I can, thank you.
Perfect. So what I wanted to start to ask you about is the last point that you were making about implementation. It seems like there is a will and an interest, and people understand the importance of PROs. However, we're still not implementing it completely full out, neither in clinical trials nor in clinical practice. So what do we actually need to do that? What is the next step that we need to do? I'm thinking carrot and stick. Do we need to make it mandatory in development? Is that what we need to do?
I'll try to put it on. Looking forward to hearing my colleagues' thoughts as well. Not a fan of making things mandatory. There are definitely opportunities to make changes. So for example, FDA does have guidances on early involvement in working with the companies in going through a clinical outcomes assessment program to identify PROs that are most relevant for newer therapies that do not seem to be off-the-shelf instruments, which are more applicable and specific to the patients. More effort needs to go in that direction. A lot of the times, PROs are also an afterthought as they learn through the clinical programs. That also takes away the application and true utilization of such instruments going ahead in the future. So perhaps thinking of them early on in the preclinical program would definitely be helpful. Identifying what's most important for the patients early on would be helpful. But that's also the first part. We also talk about patient-reported outcomes. We are also missing, perhaps in my opinion, the provider expectations. It's a lot of these times, it should also help a provider to be able to make a decision based on the PROs that they are looking at, that they are being incorporated in the trial. So provider voice that resonates along with the patient voice would be extremely necessary to go hand in hand for true success of the treatment and success of the patient as well. But over to those.
Well, that was a great answer. I don't know much more I could add. I don't agree they should be mandatory, but I think it's important, and more sessions like this will probably spark interest. I think to the agency, I mean, I gave you the heart failure example. The agency is willing to engage on developing, disease, patient population related outcomes. And so it's just trying to take advantage of the agency, and I think there has to be an agreement with the agency that ultimately we can use these for other purposes, or in place of. And heart failure is a great example. We can do a 12-week heart failure assessment in heart failure patients and basically say, yeah, you've essentially proven that you've improved patients' lives and ultimately will outcomes. I think we need to do that in type 1 and other disease spaces as well.
I think I can also respond really quickly on this if you guys hear me okay. I think with, especially under cell therapy, some of the things I talked about, and I agree with my colleagues here, it's hard to mandate something when you're in the early inception side of innovation, specifically in cell therapy. And I also think that when you look at, PROMISE is an example where it was, generally applicable across clinical research. And then they have specific domains under it. So I envision that as we move forward with innovation, we may have kind of an umbrella PRO system. And then with each domain, it really addresses the innovation and changes that happen with innovation and what patients actually value based on that therapy or product. And so I think there's still some more work done. And specifically to cell therapy, we don't know what they value. We don't know what that intermediate level is that is enough for them to take risk tolerance and to participate. So I think, it's too early given the tremendous speed we're going at diabetes innovation, especially in the last few years. I do think there needs to be some standardized format, but we're still learning.
I wish I had gone first. I think one of the things I would like to point out that probably hasn't been mentioned yet, but picks on your point, Dr. Jigar, is support in terms of funding research that actually keeps psychosocial outcomes as the primary outcome. We should, I think for very, very, very long have kept glycemic outcomes as a primary endpoint, which is awesome and should be done. But at the same time, I think given the evidence that we currently have, it's not possible to ignore that. And I think it's important for us to support studies that go out and say, I am going to look at quality of life as the primary outcome, and then see how that fares when it comes to glycemic endpoints, so that we can at least start discussing PROs in the same breath and have sessions like, that's why I said I congratulate JDRF to have sessions in primary conferences where we are giving attention to the fact that we need PROs.
And definitely this is a first discussion in a long row of many, I hope, and we should definitely continue that. And I'm coming back to a very key point here, which is the instruments that we're using in the clinical trials, and it relates to your point about funding and developing new PROs. And Monsi was talking about how interviews could be an alternative to PROs, but how do we standardize as a community what we measure? And how do we do it in an MA that is comparable? Coming back to Sanjoy's point about apples and oranges, how do we make that, well, suitable for everyone?
So I'm not giving my chance again. So I think one of the ways, at least being a PRO developer, we need to also pay attention a little bit to how the PROs were developed. And I agree with you, Jigar, that we have a list of long diabetes-specific measures that can be used. But I would also invite people, before they select PROs, to decide and to understand how the PROs were developed. So very few PROs currently exist that have actually started or developed based on patient-reported outcomes or interviews. There is an entire science to PRO development. So doing 5 interviews and then thinking these are the top items and then pushing out a PRO is not, they're not reliable and valid. So to start paying attention to development of PROs, publish the development of PROs in top journals, which is also a call out to journal articles, which I see few and fewer journals actually pushing out development of PROs as articles, which are extremely important. We will never pick up a test, and standardize a test and start using it without a significant discussion and publications around it. We should not do that with PROs either. And there is an entire science behind PRO development. So let's start asking difficult questions. You use that particular questionnaire. How did you decide that? Who published it? Before we start using this and making changes in treatments.
My esteemed panelists have covered most of the ground. I'll make a couple of points here, and they're related. One is in therapy development of any kind, whether it's a device, a drug-based therapy, a cell-based therapy, or any other, there to have a couple of considerations, which I think everyone is aware of. One is bring the patient to the trial. Don't bring the trial to the patient. So what we do typically in R&D, and I've been in pharma before, I've been in academia before, now I'm at JDRF, is we do a design of a trial, we devise a target product profile, we certainly know the unmet clinical need or the medical gap there, and then we go seek for recruitment. In the planning process, can we involve, along with your advisory committees and along with our clinical and all other committees, can we have the patient as part of the member? And we are doing that in some of our consortia, such as in some public-private partnerships that we have now. So bring the patient to the trial, don't bring the trial to the patient. It's going to be an uphill battle, and we will not be able to meet the patient where we need to meet them. The second and kind of related point here is that we talk, at least I do, very flippantly about unmet medical need, unmet clinical need, But can we also think about unmet mental need? When we bridge that gap, we think about the A1C gap, we think about the hypoglycemia incidence, we think about type 1 diabetes incidence and prevalence, we think about renal and cardiovascular complications. Do we think about the psychosocial gap in there as we think about therapeutic innovation? So two kind of related points is bring the patient to the discussion, don't bring the finished product to the patient and say, hey, let's see if it works for you.
And just, if I may add to that, completely agree, Sanjoy. I think that, when discussing interviews specifically for the work we're doing, it's really to determine what's important for patients, as we are patient-driven. And absolutely value their input in informing what did well, what we need to improve in trials, especially as we get efficacy, what's important to them as we move forward. And that really will inform how we determine our clinical trial design. So I completely agree bringing the trials to the patient. Their value and input really will determine the most successful pathway to get therapy to them.
I think that's a very good point, the fact that we do have treatment choices. It needs to be about personalization for the patient at the center, and we do have options now. And I think that's what the interviews bring, this individual perspective. But I'm thinking in terms of age groups, different populations. Are we covering everyone, or are we still missing instruments? Are we missing perspectives, especially? Sort of a question.
I would rather see it as an opportunity with new therapies that are coming up. There is lack of standardization, sure, but with the new therapies, the diabetes treatment satisfaction question is not going to apply anymore. You would have therapies in the future that are once-in-a-lifetime treatment. You almost treat the patient. Why would they care about a diabetes treatment satisfaction? They are not going to take insulin every day. Sure, so it changes. Like that picture, how do you quantify a child being able to climb a tree? That's very important for that child, not so much for, say, an adolescent or an adult, but it's an opportunity to be able to give voice to it. I think we are still not giving enough voice, even with the existing treatments, but power to Hersimran, power to the Tandem team, power to Mansi for creating those exit interviews, power to Mike Davis for incorporating this endpoints within the trial. It gets the ball rolling in the right direction.
Please. Sanjay, do you want to say no?
I do think, just specifically to your question, Jeanette, I think, in my view, I think the pediatric and the older adult population are ones that I think we have significant gaps. I think we have a proxy for pediatrics. I think we are assuming, we are making relatively safe assumptions, but I would hate to think, and I think when we are talking about patient-reported outcomes and we are saying, let the patient speak, let them see what they're feeling. I personally think we are doing a fantastic job from this 30 to 50-year-old group. But I think when it comes to minority groups, when it comes to individuals who may not have English as the first language, majority of our PROs were developed on white populations. Those are things that we need to accept and understand, that the incidence prevalence of diabetes is changing. The diabetes patient population doesn't look what it looked like 20 years ago. Are we ready for that? So to make assumptions based on how they were developed, I think is not going to work for us long term.
Thanks.
Hello, Eduardo Cagliari from São Paulo, Brazil. First, congratulations for this table, Sanjoy, because it makes perfect sense to talk about patients in a technology congress. My question is, when you want to measure the impact of a device or a treatment for a patient, you can use PROs, you can use quality of life, also resources. And sometimes for us clinicians, the concepts kind of overlap a little bit. So having you from research and industry here, do you think that we need both, that they are measuring different concepts, or do we need to increase more only PROs or more quality of life results when we want to measure the impact of this new treatment for the patient? Do you think that these concepts can be overlapped, or they are completely different and they should be measured separately?
That's a wonderful question. Thank you for asking. And I think this is where we, people like myself and everybody here on the panel, probably if I can speak for you guys, needs to take ownership. And I think, we need to do a better job when we are talking about psychosocial, and you mentioned that, and Dr. Tata, that when we talk about concepts like treatment satisfaction, it's very clear to us, just like a proper clinician, there are things which are very important to you and clear to you. We have not done a very good job of describing that to people, to lay people, or to people who are clinicians and their primary core is clinical outcomes. So first, we should do a better job of explaining psychosocial health, what it means, what are the concepts that are important. And yes, as a psychologist, I can tell you there are significant differences in what treatment satisfaction means and what quality of life means for patients. We have papers that have been published. But again, to your point, we haven't done a good job of making sure they're publicized and reach the people who are actually doing it in the clinic.
Do you think that this is because we don't have it structured, or a big concept that everybody uses the same, and this could be something that the JDRF, as an example, could develop? Let's say one questionnaire, like we have one HbA1c. Is it possible to have just one questionnaire where you have questions that everybody can answer and you can compare results?
Absolutely. I mean, JDRF has put a stake in the ground here, and my colleague who's chairing this here, Dr. Soderberg, is actually working very hard to have a strategy around this. And I'll encourage you all to bring ideas to the table here. But we're not saying that it's going to be personalized to the individual, but at least to subsets of individuals that can be. Right now, I don't know if it's one size fits all, as Manasi said. I heard last night at a dinner that it's one size fits no one. It could be even that. So and so there's a lot of room, as Jigar said, in terms of optimism here. We can only do better. We can only do better now. There's another question from the floor.
Hi, Bruce Hellman from the UK, founder of a software company, Umotif. We capture electronic patient-reported outcomes, and we're working with Pratik Chowdhury and the Hypometrics team to help patients capture lots of data. I think it's been a fantastic panel. I can't believe PROs aren't captured all over the place, because we're all about patients and we should be capturing their experience. It's interesting. I'd be keen to see the panel's sort of opinion of things like the 21st Century Cures Act in the US, which mandates more and more capture of patient-reported data. I think the question I wanted to really ask as well is, what's the thinking behind using PROs not only for the clinicians and for the research, but also to empower people more, to feed that data back to patients? We've seen that be incredibly powerful across Parkinson's, cancer, and other areas as well. So not just using this data for research purposes, but let's use it to help empower people at the same time. I'd be keen to get the thoughts on that.
I suggest, Jeanette, you answer the question.
Actually, I think Mansi.
Oh, Mansi, go ahead.
Okay, great. So I think that's a great question statement. I will say that I agree with empowerment, and I think that's really what drives patients into research, when you empower them to be part of the process versus just in the process. And we found in our clinical trials as well, from the very first clinical trials we did, and then moving forward, we all encourage all the investigators really to reach out to the patients, to ask and interview them and see what they valued and how they felt things needed to change within our clinical trial process. And that actually informed many changes that were made over time. And that's actually driven recruitment as well. And that's because patients were part of the process and they understand that this is for them.
I'll just complement that by saying that, of course, the patient needs to be empowered, needs to be feeling that they are in control, because they are in control. This is their disease and this is what they live with every life. And we have several different consortia that are working on this. How do we use outcomes to drive a valuable care and empower people to do the choices that are meaningful for them? Climbing trees or doing whatever it is that is meaningful for you as a person. We can only do more in that space. Hyper-Resolve, as you're part of, is one piece of the puzzle. You got a lot of initiatives in the EU that is driving that. But on a global scale, I think that we need a consensus on how do we bring patient forward. There is a willingness. There is people who are driving this, but I think that we can accelerate and step that up a bit.
Thank you.
Good afternoon. I'm Marta Hernandez from Spain. I have two short questions. The first one is that in clinical practice, sometimes it's not easy to measure this PRO because, for example, the DTSQ questionnaire, as far as I know, we have to pay for it, and we have to do a lot of bureaucracy. And could you please make it easier for us? It's a question or a complaint.
What's the second one?
And the second one is if you have analyzed if there are different PRO from male and women, with a gender perspective of this PRO, because I'm convinced they must be different, can be different. Thank you.
So I agree. I mean, even designing the clinical trial, we had to keep in mind that we had to pay every time we used these. So that's why one of them we would only collect it at 24, and the other ones we would collect it out to 52 weeks of multiple times. So yeah, there's a cost perspective even when designing the trial. From a gender, again, I think it's the one size fits no one type of approach. When we look at it, we do subgroup analyses on these data. We see, similar responses within our trial. And so, but again, I think the questions also, it goes to different people. It's like, what is your goal of treatment? And from a female perspective and from a male perspective, it's different. And maybe these simple questions don't get at that. So.
But in short, in short, we'll say that the first question or the first comment you made is the main goal here is the implementation science around it. That's going to be a very, very big nut to crack, but we'll be at it. But the part of the second question, it belongs to the not some of the heterogeneity of the patient population, and gender is one aspect, age is another aspect, duration of diabetes, your socioeconomic condition you're living in, because the PRO for someone who's fully insured and living in the United States is going to be very, very different for a PRO in sub-Saharan Africa. Yeah. And we are currently funding research in both places. And it is, again, the apples and oranges to the apples and apples. But I think we're up on time.
We are up on time. And just one last piece to your point, it's not only the cost to the centers, it's the burden of collecting these and entering the data. And all of those things are implementation science pieces that we need to address as a community and make it easier to empower people, but also to make science better and drive development forward. So super important questions. We are 15 minutes over time. Thank you so much for staying and listening to us. Thank you so much for my fantastic panel who's been here. And again, I think this is the first discussion in a row of many. Thank you so much for today.
Thank you.